Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital. I'm the vice chair for quality and innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over to their president, Liz Muggah, to introduce the session. Liz?
Thanks so much, Tara. So good morning, everyone. We realize this is our 49th session, so pretty exciting. I don't know what we're going to do for 50, but we're really happy you're here for 49. We have an incredible panel. As you know, they're going to introduce themselves in a second. Just wanted to remind you that this is Main Pro accredited. Details there. The next slide. I'm going to read the land acknowledgement. So we acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and their well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from and commit ourselves to gaining knowledge to forge a new culturally safe relationship and contribute to reconciliation. And if you just go to the next slide, I think we know a lot about the challenges in our sector right now, and then the particular fragility of the North. A long-standing issue, but made worse by the HHR crisis and everything that's come with COVID. And this is a call out, which is pretty concerning from this one community up in Saskatchewan, with only 3 nurses, no physicians for their 1,900 people, so a state of emergency. So just the call to action that I know we all feel in all our communities, no matter where we are, but particularly in some of our more northern and Indigenous communities, what this actually means for on the ground for the people in those communities. So work to do and attention that needs to continue to be paid. Back to you, Tara.
Thanks, Liz. As Liz said, this is our 49th session. Hurrah. Thank you for being with us through all of this. We've got, lots of prior recordings that you can go to in our current session. The video, as well as all of the resources, will be posted afterward at our website. I wanted to specifically note that our conversation will build on previous rounds we've had on long COVID, specifically those on February 18th. So you may want to check those out afterwards for some additional context. And a shout out to our planning team who's helped to get us this far. Next slide. So we've got a terrific panel today, and I'm going to turn it over to them in a moment to introduce themselves. Next slide. And then this is this is a special one because this is going to be our last session with David Kaplan. And it's going to be our last session with Liz Muggah as the OCFP president. Delightfully, she's going to stay on in a different role, and we're going to talk more about that later. Next slide. Angela, I'll turn it over to you first to introduce yourself and your conflicts.
Thank you. Thank you for inviting me here. I'm Angela Cheung, academic general internist at University Health Network, University of Toronto. And I have received honorarium from Roche, and Medicine Nova actually is providing a drug for our RECLAIM trial. This is the interventional trial for long COVID. And otherwise, you can see my other disclosures on the slide, and I have received honorarium from OCFP for a session that I did on long COVID on January 2022.
Thanks, Angela.
Thank you.
Jennifer?
I'm Jennifer Hulme. I'm an emergency physician and addictions physician, but today I'm here as a person with lived experience with long COVID. So I do not have any grants or research support for this. I do receive a small honorarium from the OCFP. Thanks for having me.
Adam.
My name is Adam Brown. I'm a physiotherapist from Toronto. I'm the founder and director of Cornerstone Physiotherapy. I also received this grant for this session.
Gerald.
Yeah, hi, Gerald Evans, lived experience with COVID, as you can hear from my voice. For those of you who know what I normally sound like. So I'm an infectious disease physician at Kingston Health Sciences Center in Queen's University. The only thing I have to declare is the fact that I am now on the defunct and no longer existent Ontario COVID-19 Science Advisory Table.
Next slide. And David.
Good morning, everybody. I'm David Kaplan, family doctor in North Toronto. I am the vice president, as you heard, at Ontario Health. Do receive an honoraria from the Ontario College of Family Physicians. I probably should add, just given the nature of today's session, that we do advise, or my team in the quality division advises the government of Ontario on its long COVID strategy, and we actually put together the post-COVID clinical advice for primary care earlier this year. So a little bit conflicted given the topic, but try to be unbiased.
Liz?
Good morning, family doc in Ottawa, and president of the Ontario College for just another 2 weeks. I'm now the incoming, starting the early September, as the senior clinical advisor for primary care for Ontario Health. So great to be here.
Thanks. And I'm Tara Kieran. I've listed some of the grants and honoraria that I've received. None of them, I think, pose a conflict for today's talk. Next slide. So as usual—
Tara, I don't think we can hear you.
You can't hear me? You can
You're all good.
Okay. As usual, your participation is what makes this alive and really a community atmosphere. So please do put your questions in the Q&A. And then if you have comments, if you have resources to share, just want to connect with those on the session, please just put those comments in the chat. We currently have about I think almost 600 people joining us right now. I know there are almost 1,000 registered, so we'll do our best to try and get to as many questions as possible. Next slide. Just so that you're aware, we're going to start by talking about long COVID, and the first half of our session will really focus on that. We're going to start with Angela talking about the science, then we're going to have Jennifer give kind of her personal perspective, and then we're going to hear from Adam, where he's going to talk about rehab supports and kind of that broader team approach. And then we'll take some Q&A related to long COVID, and then probably by 8:35, 8:40, we'll turn to the COVID update with Gerald Evans. And that'll include also some information about the new vaccine. And I'm sure some of you also have questions about boosters. So we'll get to those at the second half of our session. Next slide. So I'm going to turn it over then, without further ado, to Angela to get us started. Angela.
Oh, great. Thank you. Sorry, I didn't know that wasn't unmuted. Next slide, please. So I'm going to start with 3 take-home messages because I only have 10 minutes. So the first one is that post-COVID condition is a very real, multi-system physical condition with mental health consequences. I know that we still have some among my physician colleagues, there's still a fair bit of I would say misunderstanding, thinking that this is a psychosomatic disorder in patients with anxiety and depression. And I'm hoping to show you otherwise. So there are lots of exciting research going on, and there are interventions for long COVID symptoms. And I think we all, like me and everyone here, can treat long COVID. Next slide. So let me start with a case definition. So this is the clinical case definition of post-COVID condition that was published in October 2021 by WHO. And even though there are slight differences between, CDC, WHO, and Canada, I think Canada is going to be using this version, similar version. So post-COVID condition occurs in individuals with a history of probable or confirmed. And so I think this is the important part. And usually it's 3 months from the onset of the acute symptoms and have to last for at least 2 months. So can't be, something that's happening for a day and disappear, and cannot be explained by an alternative diagnosis. So if someone actually had migraines before and continues to have migraines, that's, not. And if someone has fibromyalgia before and continues to have that, that's also not. And the common symptoms are fatigue, shortness of breath, cognitive dysfunction, and many others, as many as 200 other symptoms. And I think the other important issue is that it can fluctuate and relapse over time. Next. So one of the things I want to mention is that there is an ICD-10 code. It's U09.9 for post-COVID condition. And so I really would encourage all of you to figure out how to build that code when you see your patients. If you bill it under fatigue NYD or shortness of breath NYD, it is a huge issue in terms of us trying to get a handle on how big a situation this can be. Next slide. So the Ontario Science Table, that actually I was a member of as well as a guest anyway, consultant, is put out recently a brief on understanding post-COVID condition, long COVID, and sort of talk about more detailed stuff that I can't get into today. And I also want to mention, because it's evolving science, we actually have also the WHO. So I submitted these slides earlier in the day, yesterday, and WHO came out with their clinical management of COVID-19. And in there, that guideline actually has 10 pages on post-COVID condition. Next slide. So why does it affect all these symptoms? That's partly because the SARS-CoV-2 virus enters the cells via the ACE2 receptor. And the ACE2 receptor has certain function. And so when there's dysfunction of the ACE2 receptor, we can also understand why there's so many different symptoms. And so you can see that there are many, it can enter all sorts of cells, whether it's in the lung, in the heart, in the brain, in the kidney, and other things. Next. So we have been doing a CIHR-funded study in 5 provinces and 18 sites, looking after many patients who have had COVID-19. And personally, I've looked after more than 800 patients with a history of COVID. Next. And if you look at the data, that is the non-hospitalized cohort, and we concentrate on the prospective cohort, there are quite a lot of people, about half the people have at least one symptom at the 3-month time point. And about a third have at least one symptom at the 12-month time point. But these symptoms actually vary depending on, one symptom that may not be affecting the daily activities or work versus someone who's so debilitated that they're lying in bed and even light and sound bothers them. Next slide. So clinically, this is what I'm seeing. I'm seeing a lot of hypertension, newly diagnosed, cognitive impairment, some diabetes, new onset diabetes, and myalgia encephalitis, chronic fatigue syndrome with what is a hallmark to this condition is post-exertional malaise, which this part, I think Jennifer and Adam will go more into. I see a lot of dysautonomia, inappropriate sinus tachycardia, POTS, or postural orthostatic tachycardia syndrome, mast cell activation syndrome, and a lot of tremors, myoclonus, seizure, dysphasia, and also reactivation of other quiescent infectious diseases. Next. So I'm going to whip through these really quickly. Fatigue, you and I know sort of how to usually deal with fatigue. We don't over investigate, try to do the basic stuff of CBC and TSH. And I would say that we pick up a fair bit of iron deficiency anemia, especially in young women. And resting and pacing is really the way to go. Next. And I want to show you that the trajectory of COVID-19 is that if you don't rest, then you actually have a lot of roller coaster. Sort of you feel better, you go back to 100% of what you did, and then you have a relapse. And after you rest a bit, you feel better again, and that roller coaster goes on. So it's really important to stop that roller coaster, because for recovery, you need to stop the roller coaster, and slowly people do return to almost the usual function, maybe 80 to 90% of the usual function. Next. People have a lot of brain fog. Next. And in our study, you can see that we have done some research testing. So I'm not suggesting that you order MRI on everyone. This is a brain stress test called CVR protocol. At the bottom is the COVID-19 patient and with brain fog, and on top it's a healthy control. And you can see a difference even without me explaining what all these colors mean. Next. The only therapy that has data is hyperbaric oxygen therapy in a very small trial with 76 patients, half in the placebo group and half in the hyperbaric oxygen therapy part. Now, this is obviously not accessible by OHIP. And if you really want to do what the trial does, it will cost the patient more than $10,000. And because it's a very small trial, this really needs to be tested in other settings. And I would say that hyperbaric oxygen therapy is not that benign. You can actually have middle ear injuries, develop myopia, have lung injuries and other issues, sinus damage and other issues. Next. So we are actually trying in our study, we're starting a study looking at sort of a oxygen and carbon dioxide kind of therapy, because carbon dioxide actually dilates blood vessels. Next. And there's a lot of headaches, and what I find is that it depends on really what kind of headaches, and gabapentin, amitriptyline, and ACE inhibitors and ARBs have been quite useful. ACE and ARBs are useful for migraine type headaches. Next slide. We find that a lot of shortness of breath, especially in the non-hospitalized population without prior lung diseases, are because of an issue with restrictive pattern. Like people are not taking a deep breath. And so we've developed some educational materials under patient resources under cancough.net and teaching them breathing exercises. It can be something like pranayama in yoga, or qigong, or what the box breathing in chest physio. Next. This is the data to support that. You can see that even in the non-hospitalized population, people have a primary restrictive defect. Maybe it's the muscles, maybe it's autonomic, who knows? But breathing exercise can help patients. Next. Post-viral cough, I won't go into, and this is easily sort of fixable with some steroid inhalers and nasal sprays for sinus congestion. Next. I won't go into this in detail. Jennifer will talk about how to diagnose POTS, but simple things like fluids, rest, and compression stockings can help. And sometimes some medications like ivabradine and beta blockers. Next. I wouldn't over-investigate their guidelines from the Canadian Cardiovascular Society on this particular issue. Next. In some of our patients, when we actually do cardiac MRI, and again, I'm not suggesting that we do order this, you can see late gadolinium enhancement on the right compared to a control on the left. Next. So in summary, post-COVID condition is a very real multi-system physical condition with mental health consequences. So think about HIV in the early days. You can do it. There are interventions for long COVID symptoms. Next. And we do have another CIHR funded study. It's a platform trial for long COVID, aiming at the root causes, which is listed on the right, like residual virus or viral particles, inflammation, immune dysregulation, endothelial dysfunction, mitochondrial dysfunction, and other issues. So it's currently going through Health Canada and CTO for approval. Next. Next slide. And I'm going to stop here. Next slide. These are my contact information, and I'm going to pass it over to Jennifer.
Thank you, Angela. A terrific presentation, really nice and succinct. Maybe before we go to Jennifer, I might just ask you a couple of questions that have come up, and then we'll go to Jennifer. So one question that people have asked is it still the case that vaccines lower the risk of long COVID, even in those who get breakthrough infection?
Yes. Vaccines will lower the number of symptoms that you get when you get COVID infection. And we know the number of symptoms that you get is correlated to whether your risk of long COVID. We see more long COVID in women between the ages of 35 and 65. And we're trying to understand whether that's a social determinant issue where the population is really hard to rest after the acute infection because of the sandwich population, or whether it's a hormonal issue and other kind of more physiological issue. But if you actually got your vaccines, you're less likely to have long COVID.
Great. And then one more question, and that was, lost it here, is the risk of long COVID lower in kids?
The risk of long COVID is probably lower in children, but we are seeing long COVID in children. Between the ages of like even 8 up to sort of, teenage years, with concentration probably in like the 14 to, 20 to 18 kind of range. We shouldn't take it lightly when kids are complaining that they're tired, they're not misbehaving. I didn't get a chance to say that there's a lot of stigma. And because there's a lot of misunderstanding, we really need to validate and try to be supportive and try to treat.
Thanks, Angela. And so I know David Kaplan and Gerald Evans have also written some responses to those questions with some links in the answered section, so you guys can check that out. And I'll go next to Jennifer, because Jennifer, I do want to just give a shout out to you for being courageous and being able to share your story so publicly, because as Angela mentioned, there is a lot of stigma, and it helps that we're able to talk about these things transparently. So thanks, Jennifer, first of all, for encouraging us also to have the panel today, and then for just being open and public about this dialogue.
Thanks, Tara. So I became so sick with long COVID and really felt very isolated. And I wrote about my experience only 6 weeks after getting really sick in Healthy Debate, really just because I felt this like strong need to communicate really to other health providers and to other people suffering. And I received responses from people like around the world. And I hope to sort of share what I've learned so far today. Next slide. So my learning objectives are very simple. It's really just to understand how sick people are. This is what people want you to know, because everyone looks well. And everyone tells me, you look so well, and this is sort of, I think, something very common in chronic disease that I didn't appreciate until I got sick myself. Know how to screen for and treat POTS in family practice, because you can really make a huge difference in people's quality of life. And have an approach to prescribe medications. I'm here in part because my family physician is probably the reason I'm standing and talking to you today. And I'm so grateful for her willingness to experiment, right, with off-label use of medications with me. And hopefully you'll have be a bit empowered to do the same with your patients. And also, it's just really important, long COVID or myalgic encephalomyelitis, rehab is not like anything that we've done before, right? It's really important that you're not pushing people to exercise, for example, if they have post-exertional symptoms. So just knowing where to send your patients for information on resting and pacing, breathing exercises that Angela described, and fasting, some cutting edge stuff that may be helpful for them. Next slide. So my story is very similar to a number of other physicians' stories. So I titled this "Your Colleagues Are Biting the Dust" because I know of many other people in a similar situation, including other family physicians. My infection was pretty standard. I was quite sick for about 9 days. I got COVID from my toddler. I went back to work full-time. I worked 16 hours actually on day 11. I was very fatigued, but I was like, fine. I wasn't sick. Worked some overnights on the weekend. And by April 18th, I was incredibly ill. I knew what this was. I was terrified. When you look at all of the long COVID symptoms, I had all of them. One of Angela alluded to this, but one of the worst symptoms was a mix of pulsatile tinnitus and hyperacusis. So like all sounds were too loud for me. So I could not eat with my family. I could not be with my family. It was incredibly distressing. I forgot my address, and so obviously couldn't work. I sort of pushed my way into the COVID clinic and did have some abnormal vital signs also that Angela described beautifully. My SAT was low. I was training for a 10K and a half marathon, right? So my resting SAT was low. I was hypertensive. I was tachycardic when walking. And I did have that restrictive pattern on my PFTs. So the plan was really to rest and pace, do some breathing exercises, and to go off work. I engaged with my family physician. And as I said, we tried some stuff, right? So I'd read in the Stanford protocol that they had used low-dose naltrexone. And as I prescribe naltrexone all the time. So I was like, oh, that would be cool to try. And it really helped with my headaches almost overnight. And I continue to take the medication to today for what it's worth. I continue to experience severe brain fog and in June started an SSRI. And the SSRIs seem to work through this anti-inflammatory pathway. It has nothing to do with the serotonin, anxiety, depression pathway. And this was actually after, I talked to a research team that were trialing this. And I said, oh, I'm not gonna take the placebo. I would like to just try it and see if it's helpful. And overnight, the brain fog lifted for me, and it was quite miraculous. And I've since heard from people who had similar experiences after being sick for 2 years. I continue to experience, obviously, POT symptoms and post-exertional malaise. I connected with Adam, who you'll hear from, and he was very helpful in just diagnosing POTS. And I'll explain to you how to do that in your office or even virtually with your patients. So he had me lie down for 3 minutes and measure my heart rate every minute. And then he had me stand up for 10 minutes and measure my heart rate every minute. And because there was a greater than 30 beats per minute increase when I stood up, this was helpful in making the diagnosis of POTS. In July, I obtained Paxlovid through nefarious means that I will not disclose until I write my book. And interestingly, the next day I lost hearing in my left ear, partial hearing loss, and got severe tinnitus in my left ear, but I'd also had a cold. So it was unclear whether it was ototoxicity. I saw ENT who confirmed the diagnosis of sensory neural hearing loss and said, of course, there was nothing they could do for me. And my lovely family physician, on my insistence, referred me for hyperbaric therapy. And I just feel so lucky. I got my hearing back, tinnitus completely cured within 3 days, and I continued for 20 sessions and have had some other benefits. Next slide. So what do I want us to come away from my experience and the experience of others? 2/3 of people with long COVID have some form of dysautonomia, and some of them have POTS. So this is really well outlined in this paper from March of this year. and easy to make the diagnosis as I described. And the treatment starts very simply, right? So salt, water, and waist high compression garments. And my understanding really is if people are really bedbound and really sick, it is worth trying a beta blocker. And if their beta blocker is contraindicated, to try ivabradine. So, and this can be done in family practice. And this is a wonderful article to help guide your practice. Next slide. And what else can you help? Can you try to help your patients recover? Full disclosure, I am on all these things. I am doing all of these things. I actually think most people who can afford to with long COVID are also doing all of these things. And so what are the things that we can do in family practice? Certainly refer to self-management resources for post-exertional malaise, and to refer, if possible, to long COVID physio, which has been so helpful for me. Try an SSRI if indicated. And again, this goes through this sigma-1 receptor agonist IL-6 pathway, and is quite promising, although we don't have the evidence yet to support it. Some people, like I'm personally taking red yeast rice for its anti-inflammatory effects, but some people are prescribed statins. And then, it's also worth trying, and it has been helpful for some, this mix of low-dose naltrexone and low-dose aripiprazole, which is what's used in the Stanford protocol. It sounds very woo-woo, but cryotherapy, so cold baths, are incredibly helpful and discussed in detail in the long COVID community. And this also sounds a bit woo-woo, but prolonged fasting and intermittent fasting is thought to promote autophagy. And given that some people may still have viral persistence, or at least have viral debris, it makes sense that anything you can do to help promote cell turnover might be helpful. And fasting for me has been incredibly helpful. Again, as family physicians, we can prescribe H1 and H2 blockers, and they can buy over-the-counter quercetin, to help sort of address the mast cell activation syndrome, which some people definitely do get benefit from. Next slide. I just want to highlight how sick people are, and they are at very high risk of suicide. Like I was actively suicidal and I have no history of anxiety and depression. I'm a very happy person and I have a great life. So I think people's brains are on fire. And this is another victim of suicide who previously was completely well, as covered by Reuters a couple of days ago. So, there's strong evidence already for an SSRI post-COVID if there are mood changes. And, given this profound neuroinflammation, which can even cause psychosis, right, which we know, it's really worth trying treatment to help people. Part of it is insomnia, right? So if you help people with their insomnia, this can be, amitriptyline may help their headaches, but may also help with their insomnia. Magnesium may help with insomnia, but may also help with the muscular symptoms. So these are things that you can try in primary care. And I would, people will find their own support groups, but there are a couple of really well-respected ones, including Body Politic. A few excellent blogs that I've linked to here. Next slide. This is my pill box, so I'm happy to take any questions afterwards. Thank you.
Thanks so much, Jennifer. And thank you to everyone in the chat who's adding some great resources. So thanks to Ashley Verdun, who was our panelist in February, who put the WHO report into the chat. And I know Vanessa Reddit put a great article there as well. And David put that link to the science brief. So just take a look at the chat if you've missed that. There are lots of questions, I know, but I'm going to turn it to Adam to go first, and then we'll take some of your questions from the Q&A box.
Great, thanks for having me. Just go to the next slide to start. So today what I want to talk about is how you can support your patients in the rehab challenge or the recovery challenge as it pertains to long COVID. I'll speak a little bit about the program that I've developed over the last couple of years with help from others in the medical community, including Angela. And also just pull some lessons from the development of that program and hopefully highlight those for you. The main challenge with long COVID rehab is that it's very different from other forms of rehab that we've dealt with in the past. The presence of the post-exertional malaise piece, POTS, other forms of dysautonomia make it extremely difficult for patients to just navigate their own recovery without getting stuck in that cycle that Angela talked about, where people are crashing and recovering over and over again for long periods of time. On admission to the program, we see generally two patterns: that crash and recovery cycle, or people become fearful of activity altogether and bring their activity level down so low in an attempt to manage their symptoms that it's not going to lead to any improvement or progress. Next slide. So our response to that has been to leverage some tools and some technology to help people through their recovery and really coach them through their recovery. We use wearable devices to objectively measure biometric data, to measure their activity level and progress their activity level, as well as a platform that allows us to collect symptom data. That all comes into the therapist for analysis and guidance, and then we use telehealth so that anyone in Ontario can access the program. Even for people within the community, often a clinic visit is a material undertaking, and so the telehealth really helps with that. The advantage that wearable tech gives us is that it allows us to monitor the response to the intervention and help coach people to prevent that crash cycle. It also enables us to give really precise instructions. Imagine the difference between saying to somebody, I want you to be a little bit more active, maybe 10% more active this week, versus saying, I'm going to increase your active calorie budget by 50 to 450, and the patient can just look at their device and see where they are at any given time in their day. It allows us to just incrementally progress them and give really, really precise instruction. It also allows us, of course, to quantify change over time. Now, the main disadvantage, of course, is that for a lot of people, they can't access private physiotherapy, whether it's their own budget or coverage and issues, and they could certainly use help from their family physician in terms of advocating on their behalf from long-term disability and other payers. Next slide. So lessons from the last 2 years: how can family medicine help support this process? Certainly identifying POTS, post-exertional malaise, and other forms of dysautonomia early, and helping your patient to understand the behavior of those symptoms. Once they understand, in particular, post-exertional malaise and POTS, if those things are present, they'll begin to get a measure of control over interpreting their symptoms and being able to adjust their activity level and appropriately. Go a long way to validate the severity of the fatigue. I think fatigue is almost the wrong word. We're used to thinking of fatigue as just being tired. This is crushing fatigue. These are people who may have been very, very fit, active, motivated people before, who physically cannot be up and doing simple ADLs in many cases. Wherever possible, refer to long COVID specific rehab programs. And one of the great things that family medicine can do in conjunction with rehab is to dig into some of the things that become a barrier to recovery. So supporting good nutrition habits, hydration, problem solving some of the insomnia and sleep issues that people with long COVID have. Alcohol and smoking need to be limited, if not stopped. Alcohol in particular seems to have a real impact on people suffering with long COVID. And we're not talking about lots of use. People who are well into their recovery, working and doing well, a couple of drinks can knock them out for a couple of days. I'm not sure exactly why. I'll leave that to the medical community, but it seems to be a major contributor. You can certainly help advocate for access to funding for treatment. That's to long-term disability insurers, employers. In some cases, we've been successful getting WSIB to fund treatment. So whenever we have help of a physician, that's more likely to be successful. And then provide self-management resources to those people who need to manage this on their own. There's some resources at the end of this presentation. And of course, there's some that have already been shared. And the big don'ts that I think are becoming clear over time is don't push through fatigue. You've heard this already, but it will make them worse. You know, we see it time and time again. People go to an appointment and maybe they have POTS. And, you know, the conventional wisdom has been, you know, you need to kind of work through this and use exercise and push. And ultimately that causes the person to crash. I think it's worth noting that in 2 years, we haven't had anybody take that strategy and be successful with it. That's not to say there's no role for exercise. There absolutely is. It just has to be undertaken in a specific way that accommodates for those conditions. Try not to, or at least help to eliminate the thought or the position that the patient's simply deconditioned. These patients are concerned about their deconditioning, and in many cases, of course, it's true that if they haven't been active for a long time, they are becoming deconditioned, but that's not the main problem. It's not the bottleneck to getting them back to function. Their fitness will improve as their activity increases over recovery. And it gets to a point in rehab where we can use exercise to recondition them in an appropriate way. And then lastly, we see a lot of people come into the program who have been treated out in the community. They've been chasing pain, fatigue, weakness, neurologic or you know, other symptoms within a typical MSK framework, and that tends to be not successful and kind of a waste of time and resources for the individual. They need to see their symptoms as part of the larger syndrome. Next slide. So what should rehab look like? And I think the reason I want to include this was that, you know, you as the referring physician, you want to have some idea of what the patient's doing and whether or not it's appropriate. That program should identify these syndromes and symptom patterns. They should screen for POTS. They should look at other forms of dysautonomia. They should understand and identify ME/CFS and post-exertional malaise symptoms. They should start out by stabilizing those symptoms by reducing activity and developing good recovery habits. So we're bringing activity down, getting symptoms under control, and stopping that crash cycle that tends to happen with people. And while we're doing that, we're beginning to counsel them on, you know, what we call good recovery hygiene, which is the nutrition, hydration, sleep, all of those sorts of things. And then the intervention should be tailored to the symptom pattern that we're seeing up in point number 1. That might take the form of physical, cognitive, or orthostatic pacing. Pacing sounds like a very simple intervention, you know, just reducing activity and spreading out, you know, the requirements that you have in a day. It's a lot more complex than that. We're talking about, you know, increasing and decreasing your activity on the basis of how much cognitive load your day has, how much upright time you're dealing with if you have some orthostatic issues. And so it is complex, and you know, some help with that is certainly useful to people. Appropriate structured exercise, and so if people have POTS, that would start in a recumbent position, and we would be looking at a specific intensity and timeline. Different patients require a different exercise prescription. Autonomic training, we've talked a little bit about this. That might take the form of breathing exercises. We like to use you know, heart rate intervals to help people with autonomic training. but we've heard about other possible interventions for that as well. Pain management strategies where appropriate, gentle movement programs, other pain management strategies are useful just for symptom control. And then, a big part of this is just the incremental progression while monitoring symptom response. So make small changes, change only one thing at a time, whether that's overall activity or adding in a little bit more work or, whatever it may be. Wait, allow for a reasonable amount of time for the post-exertional malaise piece to occur and see if they've tolerated it well before making any other changes. And, the thing that gets people caught up and crashing again is when they change too many things at one time. And so their total activity, their cognitive load, and when it comes to exercise, we're looking at changing just one parameter. It might be frequency, duration, intensity, the modality, the position it's done in. And, it's important that they have some coaching with that if they don't have any experience with it fast. Next slide. These are just some resources that are patient facing, a little bit of education and some suggestions on where to start. Some of them are from our website, they're blog posts, and a few of them are videos that have been developed along with Angela's team at Canco. You can certainly share these if you wish.
Thanks very much, Adam. Really appreciate you taking us through this. Maybe we'll go to the next slide as well. And just, Brian, if we can go to the next slide, it'll help us to, I'm just going to flag that we've also put some self-management resources that we highlighted in our February session here too. Next slide. We've flagged some outpatient post-COVID condition rehab program. I do wanted to flag that Cornerstone Physio is a virtual program that provides post-COVID condition rehab. Of course, people do need to have coverage or pay for that, but it's virtual and available anywhere in Ontario because some people have been asking about that in the chat. Next slide. Of course, there are e-consultations available for people who need further, help or advice. Next slide. And I do wanted to also just flag that, and I know there's been some questions about this as well, is just this issue of how do we get our patients the support that they need. So my colleague Gary Block helped put together this slide that has some really excellent resources for supporting people to get the relevant disability support. There's a website you can use to figure what that might be, and they've lifted some of the common key programs here. It is really important to focus on the symptoms and functional impairment because that's often what the disability support programs look for. And of course, engaging others in complicated cases, as we've talked about. So just a reminder that all of our resources, including the ones Adam shared, others have shared, and what we've put down here, we will be sending you following the session, and it will also be posted online on our website together with the slides. I'm going to end slides, and I wanted to go to questions on long COVID, but what I might do is ask Angela if you're able to go into the Q&A and start answering some of those questions through text, Angela, and typing, because I'm conscious we're also at 8:45 and I want to make sure that we have time for Gerald, and then we'll do all of the questions at the end. We're going to be going up until 9:15 today. I know Jennifer and David Kaplan and Gerald have already been answering some of the questions in the Q&A, so please do take a look at the Q&A for some of those terrific answers to the questions. So Angela, if you could go in there and start to type the answers too, that would be great.
Yeah, I will do that.
And I'm going to then turn it over to you, Gerald, to take us maybe because I know some of the other questions people have are around the boosters. Lots in the chat about people having difficulty accessing the boosters despite them being available. Lots of questions about which boosters to recommend and where we are with COVID. So I'm going to turn it over to you, Gerald, to walk us through that, and then we'll use the remaining time for the most common Q&As.
And just, I think most of us were trying not to answer the vaccine Q&As until Gerald got his time to be able to update us. So that's why they're all sitting there upvoted with 38 and 30 votes. So
yeah. Okay, Gerald, over to you. Maybe you can pull up those slides, Brian, for Gerald.
All right, thanks. Yeah, trying to answer some stuff. I've got some data to show you that might help to answer some of those questions that have popped up. So I guess I'm just going to go very quickly through where we are sitting now on the middle part of September of 2022 with COVID. Next slide, please. So one of the things I really want to talk about is perspective here. It's really important that people kind of put everything into perspective. And I think the commonest statement we hear from people is we're dealing with the disease very differently now in September of 2022 than we were in the spring of 2020. So this is just my little thing to remind me about how you look at things. So next slide, please. We're going to take you through what is really a 30,000 foot view, and I'm going to take you down to present. So this is just a little bit of a slide to sort of show you about active cases in Ontario since way back in January 2021 when we got hit by Alpha. Then by Delta, which came in sort of two phases. And then since January of this year, we've faced Omicron 1, 2, and 3, all generated different ones. So next slide, please. The red at the bottom, by the way, is Southeast Ontario. That's my little particular pin to put on things. So magnifying this down, you can see that through these successive Omicron waves, we've seen less and less active cases. And yes, the province changed all the testing in January. So at least after January, you can kind of compare these as being roughly the same. And I think one of the things that's remarkable is you don't see a big drop off with this third Omicron wave. Next slide. And if we magnify that, you can see it a little bit better here that we peaked at about almost 20,000 active COVID cases way back in about mid-July. And that's now fallen to a little over 12,000 cases. But we haven't seen this big decline like we saw with the second Omicron wave that was driven by BA2 to this Omicron third wave driven by BA5. Next slide. So what we've seen now then is this really a kind of almost a plateauing of the average of new cases per day from a peak way back during the second Omicron wave of about 3,500. We peaked at about 1,700 during the third Omicron wave, and we're down now to about 1,100. But we haven't seen this steep decline that we saw after the previous one. And that's telling us a little bit about how things have changed with regards to public health, use of public health restrictions, and of course, summertime when everybody likes to socialize. So next slide. So right now, and this is a bit of a disclaimer, this is the last RT that we put up at the COVID-19 Science Advisory Table on September 9th. You can see that we're below 1 at the moment, but we certainly spent a considerable amount of the summer through June, July, and August above 1. And so that was going to drive up numbers, and we're seeing this decline, but it's not as aggressive a decline as we'd seen when we had lots of public health measures in place. Next slide. So if you look at hospital occupancy, sorry, I'm a hospital-based doctor, so I look at this kind of stuff a lot. This is the big picture here from the previous waves. And you can see that hospitalizations were peaked during Omicron number 1, including ICU, although ICU was a bigger problem during the early Delta phase. And with Omicron 3, we're seeing this drop off. But again, the red is ICU beds are being used a little bit less than we saw in previous ones. Next slide. So if we magnify it down to the 3 Omicron waves, you get a little bit of a better picture here that this ICU decline has been pretty substantial, but we're still seeing, again, a very slow decline in hospitalizations during the third wave. Next slide, please. And this is just a big close-up. This is the end of Omicron 2. Here's Omicron 3 with this gradual decline. The big gaps here are weekend reporting where, and this is, you can see the civic holiday weekend here, where we don't get accurate numbers from all the hospitals. And for some reason, there was absolutely no data during this day here from the province, which I look at. As you know, they only report once a week. Next slide, please. So if we look at hospital and ICU occupancy, it's kind of plateaued. It's got up about a high as 1,300 or so. We're still above 1,000 people typically in hospital on any given day. And ICU numbers have remained relatively flat and are sitting now at about 125, 127. Next slide, please. So let's look at some surrogate markers of community prevalence. So we can look at 3 things: outbreak numbers, test positivity, and wastewater. Next slide. So this is the last report that we have currently on all Ontario data on outbreaks, looking at different things like congregate living settings, hospitals, retirement homes, and long-term care. You can see this is declining a little bit. So the only thing I can tell you is that right now, this last week where I don't have the data, it looks like it's maybe starting to change in a direction. Next slide, please. If we look at test positivity, we're down at about 12.2% last reported yesterday. And I put these parameters in here. Basically, if you're below 15%, you're in not bad shape. If you're below 7.5%, you're in really great shape. Whereas we just have these at about 10 and 5. So we are sort of in the middling area of this in terms of test positivity, recognizing that that's very reliant on the kind of people who present for testing. Next slide, please. We look at wastewater detection. This is the last data that we have from September 8th. It looks like a general decline, but it's not a steep decline as we've seen with previous waves. Next slide. And if you want to look at where you live in Ontario, this is where I am here in the east. But in some places like the Southwest, it looked like it was starting to trend upwards, but most of the other ones look like they're dropping. So that might be a reasonably good signal to tell us that we're in the right direction, but this is all pre the opening of schools and colleges and universities. Next slide. So right now, I'd say outbreak numbers are looking good. I'd give it a green light. Test positivity is amber and wastewater detection is amber. So this is heading into the fall when we're going to expect to see a rise in cases due to the seasonal forcing that is common with these respiratory viruses. And by the way, it is a multi-system virus. I call it a respiratory virus because that's my just general inclination. Having suffered from this acute infection, it's definitely multi-system. Next slide. So let's, so this is just a quick picture of the variants. You can see that right now we're dominating in BA5, all of the different subvariants, which are all in purple here. This one is worth watching, Omicron BA 4.6, which appears to be starting to show some advantage in terms of its reproduction over BA5. We don't know, however, if it's going to make a big difference ultimately. And then the other one we're watching is 2.75, which has been a problem in the Indian subcontinent, and we're wondering where that's going to emerge. It doesn't look like it's doing a very good job of coming out, though, around everything else. Next slide, please. So bivalent, let's just talk a little bit quickly about bivalent vaccines. So there's a whole bunch of them that are coming out. Most of them are going to be the mRNA vaccines, principally because that's the fastest way you can manufacture them, because all you have to do is code for a different messenger RNA sequence. Moderna has 2 of them out there, and I'll call them 214 and 222. 214 is a ancestral virus with BA1. 222 is the ancestral with a BA4-5 mix. Only this one is approved in Canada. The BA4-5 has been approved in the States, and that's why everybody's hearing things. And I saw a question about, should I be running to the United States to get this vaccine over the BA1 vaccine? I'll show you the data in a second. Suggests probably not a useful use of your time. Pfizer actually has a BA1, but it's not even going through approval. They've already proceeded on with the BA4-5 mix in. The files on 222 and the Pfizer BA4-5 mix are both with Health Canada, but they're not yet approved. And there are some others in early development based on other platforms. Next slide, please. So this is one of the questions I get asked a lot is like, oh my God, they're giving us a vaccine. They've never given it to people. It's all in mice. That's actually bullshit. This is the numbers of humans that are actually included in and that have received the vaccine, and about equal numbers have received the control, which is the typical ancestral Moderna virus. So in fact, it has been used in humans. So it's not just mice, folks. And that's one of the most common pieces of misinformation I see floating around social media. Next slide, please. So if you look at the 214 vaccine, this is comparing it to the ancestral vaccine. So the ancestral vaccines in light blue, the bivalent in dark blue. PB is pre-boost, and D29 is the neutralizing antibody levels taken at the 29th day after that boost. And you can see all the participants in here. Here's with people who've never had COVID. Here's people who've had COVID, logarithmic scales. So, you know, be careful. This is a pretty high amount when you compare it to this because of the logarithmic scale. But essentially, these vaccines all induce a very significant neutralizing antibody response. And this is measured against BA4 and BA5. So that's why I'm telling people don't get too excited about waiting for a BA4-5. The BA1 does a pretty good job of giving you very high neutralizing antibody responses against BA4-5. Next slide, please. So this is now mouse data, so I'm not going to tell you about humans here. These are definitely little rodents. And what I want you to pay attention to is the orange, which is the 214 vaccine. That's the one approved in Canada. And 222 is the BA.4/5 version from Moderna. And what you can see is actually there's very little difference in terms of virus that you're going to find. This is actually looking at virus culture between these two vaccines. They're essentially pretty well the same. So I don't think at this moment there's a lot of data, and it's based on surrogate markers, to suggest that you should wait for the BA.4/5/222 vaccine. The BA.1/214 vaccine probably is giving you virtually the same sorts of protection that you're going to get from the 222 vaccine. So next slide, please. This is the data from the Pfizer-BioNTech bivalent, which was a BA.1/1. This was actually interesting because they looked at the BA.4/5 response, which you can see in light sort of blue here, compared to BA.1 response in dark blue. And they actually did show that looks like there was at least a significant, perhaps slightly significant level of less protection against BA.4/5. And I think that's why Pfizer's abandoned doing the BA.1 for regulatory approval, and they're going ahead with their BA.4/5 vaccine. So when it comes to the Pfizer vaccine, the BA.4/5, may have a better stuff, but I don't have that data. It's not available at the moment. Still under curfew. Next slide, please. So basically, the bottom line with the bivalents is that, yes, they're studied in humans, not just mice. So you can tell your patients that because they're hearing about only mice. I didn't show you the data, but the adverse effect profile reactogenicity in human subjects is identical between the ancestral vaccine and the bivalent ones. It does show improved levels of neutralizing antibody versus all of the Omicron variants, and that includes BA.4/5. It is likely to provide better protection or sterilizing immunity against Omicron infection for about 3 to 4 months after you receive the vaccine compared with the original vaccine, just simply because those high neutralizing antibody responses tend to correlate well with prevention of infection. But what they all do, of course, is they continue to provide protective immunity, which is equivalent to vaccine with the ancestral strain, which prevents you from getting serious disease. I'd love to see what serious disease looks like. I've had 4 vaccine doses and I felt like crap during my experience with COVID. Next slide, please. I think this next one, this is a question that's always popped up. What about giving influenza vaccine with COVID vaccine? This is a study from the US, which basically showed there was little difference whether you got the Pfizer or the Moderna simultaneously with an influenza vaccine. And they looked at over 92,000 people. So these are essentially, again, some of these local reactions are pretty common, but when you look at any health impact, they're really not there. These 95% confidence intervals cross 1. So we can administer them together. The general concept, I think, is that you need to use it all your vaccine opportunities. So do I have lots of data on, co-administration of childhood vaccines with COVID vaccine? I don't have a lot on that. And there was a general consensus that you should separate them by about 2 weeks from NACI, but I'm not sure that that's necessary. And then the last 2 slides I have, next one, please, is popped up in questions, which is what does vaccination do in terms of the development of post COVID sequelae or long COVID? This is a US study that showed a significant reduction by vaccinating people who've had vaccine and COVID versus no vaccine and COVID. And you can see there are quite substantial reductions in some of these symptoms that patients develop since the onset of COVID. And then the next slide is from an Israeli study, which looked at the same thing. Vaccinated people are in these purple ones, and unvaccinated people are in blue. And then, of course, they actually had a control arm of uninfected people. These are a whole host of symptoms they looked at. But you can see here generally that essentially having the vaccine seems to significantly reduce the probability of developing some of these symptoms which are associated with a post-COVID condition. And I think that's my last slide, if I remember right. So I'll stop at that point.
Thanks so much, Gerald. I'm just going to flag a few other resources for folks. So let's go to the next slide. So this is just a slide summary of who is eligible for the bivalent vaccine in Ontario. So as of September 26th, anyone 18 plus will be eligible. Before September 26th, it's only those in certain vulnerable group categories, including those 70 and over, residents of long-term care, First Nation, Inuit, and Métis individuals and their household members, immunocompromised, pregnant, and healthcare workers. And so they're eligible regardless of the number of boosters that they've received. And the recommended interval from the previous dose is 6 months, with the minimal interval being 3 months. And so we have some links here for more detailed guidance. Next slide. I wanted to just highlight that VaxFax continues to be an excellent resource for your patients with vaccine questions. They have actually tried to have some very specific programs to meet specific community needs. So they've got a VaxFax for Black communities, VaxFax for parents. So lots of supports there. So for people who, if your patients don't have family members or friends who don't have a doctor, or if it's a time-consuming process for them to be able to speak with you, you can always refer them to vaccine. Next slide. I wanted to just shout out to Andrea Chittle for continuing to keep Confused About COVID.ca up to date and including this booster dose document. There have been some questions in the Q&A and chat about intervals for the different and eligibility, and this kind of really helps to break it down. And so thanks also to our DFCM and OCFP team to continue to keep that up to date. Next slide. This might be the last one on vaccines. Oh, okay, and this is not related to vaccines. So we'll just end slides for now, and we're going to do some questions and answers. So thanks so much, Gerald, for that terrific overview. I think you answered a lot of people's questions. And I also noted, Angela and Jennifer, you've been furiously answering questions in the chat and the Q&A, which is amazing. So let me just take a few questions related to what Gerald was speaking about, and then we'll switch back to some long COVID stuff. One just common thing that seems to be being asked about, Gerald, in different forms is, there are a lot of questions about whether to take the vaccine that's offered now or to wait for the newer bivalent. And I just gonna give that to you again.
Yeah, I'm my general consensus, my general view on this is if you're young and healthy, you're doing everything you can to avoid COVID, which is pretty hard these days, by the way. You can probably wait. I suspect there will be approval of the BA.4/5 vaccine from Moderna, the 222, probably within the next 4 to 6 weeks. I think if, however, you're older, and when I say older, that means you're at least my age, if not older, but then getting the vaccine, the current bivalent vaccine, if you are eligible, and you will be by the end of the month, even everything else aside, I would go for it. I do not see an incrementally huge benefit based on surrogate marker data that the waiting for the 4/5 bivalent is going to be a substantial improvement over what's currently available with the BA.1/1.
And so Pfizer, it seems like Pfizer submitted their request for their BA.4/5 targeted vaccine. And do you have any insight onto when we might expect approval of that?
I always like this because actually I have no relationship with pharma whatsoever, but I'm always supposedly on the inside of all this information. Yeah, I think their file is now complete. So that means usually you're looking at about a 4-week interval to determine whether it's going to be approved or not by Health Canada. That again is going to be based on, a lot of this is based on the fact that the current platform works. They're not worried about safety issues. It's just the mix that's in it. And there's no expectation that that mix is going to produce, as I sort of suggested, looking at the comparative Moderna trials, with reactogenicity or adverse effects. So I would say you're probably looking for approval again along the same sort of timelines, likely in the early part of October. There is some interesting, there's a paper that was published about a year ago that compared the antibody responses from Moderna versus Pfizer, right? There's always been this Moderna versus Pfizer thing going on. And the fact of the matter is that there is some subtle differences in the antibody profile that's generated by both by the Moderna versus the Pfizer vaccine. And there's actually a reasonable suggestion, I think, for those of us who know a little bit about vaccine science, is if you have an opportunity to mix them up, you should mix them up. I don't think you should be, what's the word, sticking to one brand or the other. So if you've had Pfizer, and many healthcare workers, of course, had Pfizer because that was the one that was most broadly available in Ontario. If you have the opportunity to get the Moderna vaccine, I would get it. I think there's a potentially small benefit to the sort of coverage of what you're getting in terms of antibody responses to the spike protein by mixing up Moderna with the Pfizer.
So the other question that seems to be coming up quite a bit is, should I wait the recommended 6 months or do it early at 3 months, especially given now that we're getting into the fall, or that I might be a healthcare worker and I have more risk, or I work in another kind of setting that has more risk?
Yeah, it's fascinating. There's a lot, even amongst my colleagues, there's all this discussion about when you should get your flu shot this year, because the Southern Hemisphere had an early season. And some of my colleagues say, I always wait till November. So I think when you're eligible, and if you're eligible, you should probably get it. The one thing is there was a paper just recently released that suggested that within 6 months of actually having had COVID, getting the vaccine does not produce as big an incremental response in immunologic assays that we see, so neutralizing antibodies or T cell responses. So there is a benefit to delaying any kind of vaccine out to maybe about 6 months if you've just had COVID. I've clearly had a BA.5 COVID recently, so I'm probably going to wait, even though I project and expect that there's going to be a rise in incidence towards the later part of the fall. So it's always a bit of a tricky thing. I think the general consensus is if you've got access to it and you're at least 3 months out, especially if you're vulnerable, go ahead and get the vaccine, whatever current bivalence available. And don't kind of try and nuance it too much. And of course, get your flu shot and your COVID shot at the same time if that's what you're going for.
Yeah, so that's the last question I wanted to throw to you for now, Gerald, was around the co-administration. So I think you gave good data around co-administration is fine for adults. For children, I believe it's still recommended that maybe you could go over what the recommendation is for children around vaccines and other immunizations.
Yeah, so
other immunizations.
Yeah, both NACI and APIC in the States have suggested that you should probably be separating COVID vaccination from other vaccines, regular childhood vaccines, by about at least 2 weeks, and maybe even ideally 4. But as everyone knows, really having some challenges getting childhood vaccines. We've fallen way behind just by the nature of this crazy pandemic. I think that's just a general recommendation based on known vaccine science and the sort of immune response you're going to get. I think ultimately we're going to see some studies that are going to show that you can probably co-administer them. I mean, for all of you guys, and you guys administer childhood vaccines all the time, you give 7 antigens at the same time. I mean, it's not like the immune system is that weird a thing that it doesn't know how to handle different antigenic determinants. And I think we're just being cautious when it comes to the COVID vaccine and childhood vaccines.
Thanks, Gerald. So I'm going to turn it now back to long COVID. I did want to give thank Ashley Verdun for putting some resources into the chat around where you can access OHIP covered rehab, because many of the other options are private. I think Carrie Bernard also has, shared her own kind of struggles with long COVID, and I thought had like a really nice quote in the chat around, it's like choosing wisely, less is more. The hardest part of my recovery journey with Adam has been to learn how to do less, which was very hard for as a physician. So thank you, Carrie, for sharing that. And I think it really emphasizes one of the take-home points from the talks today. I wanted to turn it over to you maybe first, Angela. You've been answering a lot of questions in the Q&A. Are there any that stand out that you wanted to highlight to folks verbally?
I think one common question that I'm seeing is that people ask, like, if they have had COVID, should they get the vaccine? Certainly, if you have had your vaccine, I think Gerald answered this question as well, that in terms of booster, you can wait 3 to 6 months, and depending on really how high risk you are for getting another dose of COVID. One issue is that every COVID infection may be slightly different. So some people feel So I've seen patients who have had 4 COVID infections, and even if they didn't get long COVID the first time, they can get long COVID in the subsequent infections. So you do want to try to prevent further infections.
Jennifer, is there anything that you wanted to highlight?
No, I mean, there are still a lot of questions about whether the vaccine can cause long COVID symptoms, and unfortunately it can. And I assume through the same sort of autoimmune, immune dysregulation pathway, but of course it's much more rare, and I wouldn't want it to contribute to vaccine hesitancy. And there are a lot of specific questions about treatment, which hopefully will be answered through the links in the PowerPoint presentation that you can access afterwards.
Thanks. So I will go through just a few of the top questions here that you guys spoke about. So I think some people have also been wondering about the role of Paxlovid in preventing long COVID, and I wonder, Angela, David, or others, if you wanted to comment on that.
We don't really have a lot of data on that issue. I think 5 days of Paxlovid may not actually help long COVID. So we're really talking about sort of a longer term antiviral, whether it's Paxlovid or something else. And we are working actively on trying to procure something for an arm and reclaim. The other issue with Paxlovid, I know it's now more available and sort of by anyone writing a prescription, is that you have to really consider all the comorbidities and other medications, because there's lots of interactions. And I actually find that there is a site in the UK that is very helpful, and I'll try to put it in the chat as well. That is for checking are there interactions with other drugs. And so if someone actually has renal dysfunction, you can't really give it at the usual dose as well. So there are many issues. And if the renal function is less than 30 in terms of clearance, it's a contraindication. So keep those things in mind.
And yeah, I mean, I can comment as someone who obtained Paxlovid by nefarious means. Like the main side effect, I stopped all of my other medications so there'd be no interactions. That metallic taste in your mouth is very, it's real. But otherwise I had no side effects, but I lost hearing, right? And there's this rare cause, it potentially can cause ototoxicity. I do not know whether it was linked to Paxlovid or not. So it's complicated, and like trying to get 2 months worth of Paxlovid, like good luck. So it's still really in early stages. I see Susan says that she had patients treated with Paxlovid. A lot of people do report significant benefit, but some people get better and then they get worse again, and there's a rebound effect. So I agree with Angela that 5 days is not going to be enough.
And so people are asking, are there any specific recommendations for younger people with long COVID? So for example, 12 to 20-year-olds with persistent fatigue.
So I'm not a pediatrician, but I would say that it's in the sort of concepts and principles are similar. Resting and pacing is really important. And in a younger person, sometimes it's not easy to sort of carry that piece out. Talking about it's simple, but actually, as Adam was saying, it's more difficult to put it into practice. If they have autonomic symptoms, it's, the breathing exercises can actually modulate your autonomic system. One trick that I teach my patients, including the younger folks, is actually to have breaks during the day, that they're lying down. And actually when they lie down, in the younger people, it's also easier to get them to do sort of the like feet up all the way, like an L shape kind of thing against the wall, and they're lying flat. And so that seems to help my patients as well. So not going to sleep per se, but like 15-20 minutes of sort of, that kind of position seems to help.
I would echo, we also do that. We'll often have people set a timer so that throughout the day at regular intervals will take a moment to either do their breathing exercises or just to come in and bring their heart rate down and do whatever their favorite method is.
I might just go like a couple minutes more just to get a couple more questions in. And so just wondering, Angela or others, again, and Jennifer and others, there's been, Jennifer, you talked a lot about these other supplements, and you know, I wonder if you can comment on the off-label use of them. And you know, you certainly talked about what you're taking. What's the evidence around that? You know, what should we be recommending to our patients?
So there's almost no evidence for anything, right? So there's no way that there's no money for a trial for long COVID for any of these supplements. So as I outlined, what we do have evidence of is that mast cell activation syndrome is common in long COVID, right? That we know that people have microclots. Like, we know a lot about the pathophysiology. Some people have some things, like, and that's why there's this heterogeneity, right? Like, so some people might have a strong mast cell component and would really benefit from quercetin and H1 and H2 blockers. And then the other person may not have that, and their pathophys is more related to POTS and decreased perfusion to their brain. So when people are extremely sick, what do? You throw the bucket, you know, you throw everything at it. So I can comment to say that I personally, based on my read of the evidence and my understanding of the pathophysiology, I do take aspirin. I do take, you know, streptokinase, lubrikinase, and whatever these kinases are. And I don't think personally that I have a strong component of, you know, histamine and mast cell activation, but I'm too terrified to stop the antihistamines and the quercetin. So these are just examples of, like, of course, there's no evidence for anything. But, you know, there are a lot of people, including pharmacists, you know, PhD pharmacists, who are on Twitter trying to share their experience. And as long as the supplement is safe, people are going to be trying these things. So I wanted to make you aware that everyone's taking this stuff, like whether you suggest it or not. And it's helpful to be aware of this and some of those things. And the naltrexone dose, you can titrate up it's in my presentation, but these are baby doses, so they need to be compounded by the pharmacy. Same thing with aripiprazole. These are tiny doses. Otherwise you're literally like licking the naltrexone, which is like, is very difficult. There's a lot of crumbling around your mouth. So, you know, there are some things that can be prescribed by the doctor. And the other things, of course, you can't say for certain that they're going to help people, but I think it's reasonable to say if people have the means to try different things to see if they're helpful, because people are so sick, right? And they need to feel supported.
Jennifer.
I just want to add to that. I think it's really important what Jennifer said about being supported, because a lot of patients feel that they are not listened to and that their physicians are dismissing their symptoms. I think it's really important to validate and support. And sometimes patients don't even want to talk about it because they don't want to give you that flavor that they are neurotic or something like that. And so I think it's important to for that piece. My suggestion would be really, it's evolving science. We should try to contribute to research and try to have some definitive answers. So for Reclaim, I just want to put in one plug about Reclaim, is that it's an adaptive integrative medicine trial, and we do consider sort of like supplements and other therapies that are not medications. And these are voted on by international experts and patients. And so what ended up there, in terms of our first round, we actually have all sorts of supplements and other things in there. But what ended up there is a result of people voting on that. So when it's open, would like to let you guys know as well, so that at least patients can consider that as an option.
Thanks so much, Angela. Brian, can you bring back our slides? Because I think we're going to wrap up the session. We could go on for another hour with the many different wonderful questions we have. We will be posting the session recording We'll go back one. I just wanted to flag, Brian, if you go back one, that we did have the science table brief that we wanted to flag for you guys around acute hepatitis C in kids. So if you wanted to know more about that, please do look at that. But the next slide is an important one. So I just wanted to take a moment. So we are at our 49th session, and this is a more important moment for us because it is the last one with Dr. David Kaplan, who's been here with us since the start. David is actually going to be handing over the reins to Liz, who's going to continue to join us but in a different role, because Liz is going to be stepping down as OCFP president after her 2-year term and taking on a new role at Ontario Health. And actually, maybe I'll let you speak, David, about a few words, and you can introduce Liz's role.
Oh my goodness. As many of you know, prior to coming into Ontario Health, at Health Quality Ontario, I was the chief of clinical quality, but I was also the primary care lead at Health Quality Ontario. And so we had come all together into the super agency just before the pandemic started. Not a great time to do radical system transformation. And so over the course of the pandemic, I've really sort of also, in my addition to my role as vice president of quality, really been the lead at OH for primary care. And last year, we really tried to put together a position for really somebody who can focus a lot of their time on primary care, given how important it is to our health system. And we had a very open call for a primary care lead or primary care advisor. And Liz was the successful candidate in that. And that was actually, I think at some point, Liz, in the spring, but we had to wait until you were finishing up your role as OCFP president for you to have the time to come and join us. And so, this has been a long time in coming to get somebody with Liz's expertise and cachet and real, the warmth that I think she's going to bring to the role, and not just the guidance that I think the system needs from a policy perspective. And so really looking forward to having Liz join the team, both on Sasha Batch's team in population health and value-based healthcare, but also in quality on my team as well. So a bit of a dual role that Liz is going to have with lots to deliver on. But as you can imagine, as all of us have gotten to know her better over the last 2 years and seeing her every other Friday morning, I'm sure she is up to the challenge. And but thank you for having me join here. Happy to join at any point if there is specific stuff around long COVID that's going to be coming out, just because, like I said, my team is still doing that work at Ontario Health. But from the primary care perspective, it's hats off and reins over to Liz.
Liz, did you want to say anything? I know we're short on time.
No, I'll just say thank you to David. He's an incredible leader, and just to all of you on the call for continuing to be the front lines. We do what we can behind the scenes to push forward a foundational, strong, supported primary care system and a work environment for family doctors that mean that we can continue to do what we do. So that's like all of our panelists on the call play a part of that. David plays a huge part of that. Tara, you do, but really it's all of you calling in who are making it happen. So, this is my commitment to you and to our sector and to our profession that I'll keep working. And I've got David on speed dial, so we're not going to lose all his expertise. Yeah. And we've got Hulme coming in as the president of the OCFP. She's an amazing family doctor from Cambridge. She's the chief of family medicine there at Cambridge Memorial Hospital. She's going to be incredible. Just so proud of our family doc leaders, wherever you're doing that leading, at the coalface with your patients or in the hospitals or, as a bureaucrat. So thank you.
Thank you, David and Liz. I'm going to turn it to the next slide. I am grateful that Liz, you're going to be staying on because you've been a great, you've been part of this amazing team behind the scenes to put these sessions together. And so shout out again to our team for putting this together. Our 49th session will have number 50 on October 7th. Fill out our evaluation and let us know what topics you want. Usually the recording and the slides are up by the end of the day at our website. We'll also be compiling the Q&A and a resource list and emailing that over to folks. I wanted to thank our presenters. I think Carrie Bernard again said it well. She said, thanks to Dr. Cheung, Adam, and Jennifer for addressing this poorly understood condition. It gives me hope for long-term recovery possibilities. Your honesty about what is and isn't known is very refreshing. I think in a short amount of time, you've really provided us with a lot of insight and resources. Thank you to everybody in the audience for actually supplementing it with your own experience and with lots of terrific other resources that you posted in the chat, which our team will continue to compile. Thanks to Gerald Evans for also joining us and keeping us up to date on COVID and all of our vaccine questions. I know that there were more, but certainly we'll be getting to more of those general vaccine questions again on October 7th. We'll probably also be talking about the flu shot and flu season. So thanks again to all of you. Special shout out to David and Liz for their last session in their current roles. And thanks again. Have a great weekend, everyone.